All right, let's talk about something that impacts, well, pretty much all of us, our heart health. There are brand new medical guidelines for 2026 that are about to completely change the way we think about cholesterol. And we're going to dive into what this huge shift towards personalized medicine really means for you.
You know, for decades we've had it drilled into us. There's good HDL and bad LDL cholesterol. Simple, right? But what if I told you that simple story is frankly outdated? Is that really all there is to it when it comes to avoiding a heart attack? Well, the science is now screaming absolutely not.
And that's because these new 2026 guidelines are here, and wow, they really shake things up. The whole focus is shifting away from those one-size-fits-all rules and moving towards something much, much smarter. A strategy that's all about you as an individual. I think the best way to picture it is like upgrading from an old generic paper map to a super detailed GPS. Instead of one single highway that everyone's supposed to take, this new roadmap creates a custom route just for you based on your unique health profile. It's all about finding the safest, most direct path to a healthy heart.
And that right there is the core idea. The whole everyone get your cholesterol below this one number way of thinking, it's on its way out. The new goal, the new mission, is to build a plan that is designed specifically for your body, your history, and your personal set of risks.
So, okay, where does this all start? Well, if you're someone who hasn't already had a heart attack or a stroke, everything begins with one single, incredibly important question. What is my personal risk? Getting an answer to that is the absolute foundation of everything that follows.
So here's how doctors figure that out. It's a pretty clear three-step process. First, they use these new, smarter equations to calculate your risk of a heart event over the next 10 and even 30 years. Then they look at what are called risk enhancers. You know, things like a strong family history or certain health conditions that the main calculator might not see. And if after all that, your risk is still kind of in a gray area, they have an amazing tiebreaker.
And that tiebreaker is the coronary artery calcium scan, or CAC scan. Now this is so cool because the idea is so simple. It's a quick x-ray that literally just looks for hardened plaque in the arteries of your heart. And the analogy here is perfect. It's like a plumber taking a camera to look inside your pipes for any gunk building up long before you ever have a major clog.
And check out how clear the results are. A score of 0? That's amazing news. It means no detectable plaque. You can focus on a healthy lifestyle and maybe check again in a few years. But the moment that score is above 0, even a mild score of, say, 1 to 99, the guidelines recommend starting a statin. And if your score hits 100 or more, a statin is strongly recommended. It just cuts right through the confusion and gives you a clear path forward.
Okay, so let's shift gears and talk about treatment. Because just like the risk assessment is personal, the treatment plan has to be too. The right plan for one person is not the right plan for another. It's all about tailoring it to you.
For example, if you've already had a heart attack or stroke, you're in a completely different category. The game changes. For those patients, the goals for prevention become much, much more aggressive.
For most people who've had that first heart event, the goal is pretty straightforward. We need to get that bad LDL cholesterol down below 70. That's the established target to seriously lower the odds of it happening again. But for some people, even that isn't enough. For patients who are considered very high risk, maybe they've had more than one heart attack or they have a bunch of other serious issues, the goalposts move again. The target gets pushed even lower, to under 55. You see how the intensity of the treatment is scaled to match the intensity of the risk? It's smart medicine. The guidelines also lay out these really clear battle plans for specific problems, like someone who starts with a dangerously high LDL of 190 or more. The strategy is layered. You start with the strongest statin you can handle, but if that doesn't get you to your goal, there's a whole arsenal of add-on therapies ready to go. And the detail doesn't stop there. There are specific, dedicated treatment plans for people with diabetes or chronic kidney disease or even HIV, all conditions that we know can really impact your heart risk. It's incredibly thorough.
So now I want to look ahead a little bit because these guidelines are also pushing us to go beyond the standard cholesterol panel we've all seen before. They're pointing us toward the future of risk assessment with some really advanced tests.
First on the list is something called lipoprotein A, or you'll hear it called LPA. You can think of it as a sticky, tricky cousin of LDL cholesterol. And what makes it so unique is that your LPA level is pretty much all decided by your genes. And that is exactly why it's so important to know your number, because it's genetic. Diet and exercise aren't going to budge it much.
That's why the new recommendation is for every adult to get this test done once in their lifetime. Because if that number comes back high, it's a huge signal to your doctor that they need to be extra aggressive in controlling all the other things they can change, like your blood pressure and your LDL.
The second test is called apolipoprotein B, or ApoB. And this one is really fascinating. Instead of just measuring the total weight of all your bad cholesterol, ApoB actually counts the number of individual, potentially plaque-causing particles that are floating around in your bloodstream.
I absolutely love this analogy because it makes things so clear. A standard LDL test is like weighing all the cargo on a fleet of ships. But ApoB actually counts the number of ships. And think about it. When it comes to causing a traffic jam in your arteries, it's the sheer number of ships that's the real problem, not just how much cargo each one is carrying. It's often a much more accurate way to measure your true risk.
Okay, we have covered a lot of ground. So let's boil it all down. What are the big takeaways? What does all of this really mean for you?
First, and most importantly, heart health is personal. It all starts with your own unique risk score. Second, amazing tools like that CAC scan can cut through the noise and tell you if you really need treatment. Third, treatment goals are tailored. Your target number isn't a generic rule, it's your rule. And finally, these new tests like LPA and ApoB are coming into the spotlight, giving us a much sharper picture of our heart risk than we've ever had before.
When you really think about it, your cholesterol number isn't the final word on your health. It's just the start of the conversation. These new guidelines give you the power to ask smarter, better questions, and to work with your doctor to build a plan that's truly right for you. So, what's the next question you're going to ask?